Dr. Hausenloy will speak to us about the microvascular.
Good morning, Chairman, ladies and gentlemen. I'd first like to begin by thanking the organisers for giving me the opportunity to come here and speak at this meeting and to visit the beautiful town of Oviedo. We've heard a lot in this session and the previous sessions about how it's important that we have timely and effective myocardial reperfusion in our STEMI patients if we want to improve their clinical outcomes. One subject which we've not touched on is myocardial reperfusion injury, and I want to talk about this today and just relate to you how this is an important residual target for cardiac protection, and it may be a potential strategy through which we can actually improve further the clinical outcomes for our patients. So despite optimal therapy, clinical outcomes of patients presenting with ST elevation MI and undergoing PPCI can be improved. 1 year CV death rates are about 9%, and hospitalization for heart failure is about 10%. Myocardial reperfusion injury is possibly a target which if we can therapeutically prevent this, then we can improve outcomes in our STEMI patients further. And today I will talk about some novel therapeutic interventions, both mechanical and pharmacological, which are aimed at reducing myocardial reperfusion injury. So we've talked about this, that we need to have timely myocardial reperfusion to limit infarct size. And there are ongoing improvements in myocardial reperfusion, such as novel antiplatelets and antithrombotic, and we heard this morning from Laura, novel PCI technology. However, getting the patient to this point is clearly important. But once the patients are reperfused, the presence of myocardial reperfusion injury can actually mitigate the benefits of myocardial reperfusion, and I'll talk about this next. So what is myocardial reperfusion injury? Paradoxically, when we reperfuse our patients with primary PCI or thrombolysis, we can actually induce further injury to the cardiomyocytes. And the definition of myocardial reperfusion injury is the reperfusion-induced death of cardiomyocytes which are viable at the end of ischemia. There are 4 types of myocardial reperfusion injury, but I'll mainly focus on microvascular obstruction and the last one, which is lethal reperfusion injury. There are different proponents of myocardial reperfusion injury, including oxidative stress, calcium overload, rapid pH correction, and inflammation. And if we can target these factors and prevent reperfusion injury, then one may be able to get the full benefits of reperfusion for our patients. So how important is myocardial reperfusion injury? If we look at this graph here, and this shows infarct size on the y-axis, and our patient presenting with ischemia and undergoing reperfusion with primary PCI. If they have reperfusion at this point, the expected infarct size after primary PCI may be at this level. However, the presence of reperfusion injury actually increases the infarct size. So by reperfusing our patients, we are clearly salvaging myocardium, but the process of reperfusion can actually exacerbate infarction. So therefore, this would be the expected infarct salvaged by primary PCI, but in fact, all you get by salvage by reperfusion is reduced because of the presence of reperfusion injury. And therefore, this presents a residual target for actually reducing infarct size further in our patients who are optimally reperfused. Where can we intervene to actually prevent reperfusion injury? Most of the reperfusion injury occurs in the first few minutes of reperfusion. So it's important that we intervene after the onset of chest pain, but prior to primary PCI. And this should be undertaken either in the ambulance or on arrival to the hospital. Many of the previous clinical studies which have looked at reducing reperfusion injury, unfortunately, have given interventions after reperfusion has started, and this may explain some of the negative studies. Talking about the negative studies, there have been many in this field which have focused on different proponents of reperfusion injury, such as antioxidant therapy, drugs for inhibiting calcium overload, anti-inflammatory therapy. Unfortunately, many of these trials have been negative. And this is because we are not actually addressing all the components of myocardial reperfusion injury. And one of the particular targets is the mitochondria. And if we can maintain mitochondrial function at reperfusion, one may be able to realize further benefits of reperfusion. I'm also going to talk about conditioning the heart with ischemia. You all may be familiar with the term of ischemic preconditioning, where small episodes of non-lethal ischemia can protect the heart against infarction. However, for our patients presenting with acute myocardial infarction, where ischemia has already taken place, this is not an appropriate therapy. However, there is a phenomenon called ischemic postconditioning, where one can actually interrupt the reperfusion phase with small episodes of ischemia induced by repeat balloon inflation within the infarct-related artery. And this phenomenon has been shown to reduce infarct size in patients undergoing primary PCI. The first study to show this was by Michel Ovise's group in Lyon, where they took 30 STEMI patients presenting with a ST elevation MI with TIMI zero flow and no collaterals, and patients were randomized to receive normal primary PCI, unimpeded reperfusion, or an ischemic postconditioning protocol. And in this, the postconditioning protocol comprised withdrawing the catheter and the angioplasty balloon upstream of the stent and inflating the balloon for 1 minute, a low pressure inflation for 1 minute, and then deflation. And this cycle was repeated four times. And this stuttered reperfusion, or ischemic postconditioning, was actually able to reduce infarct size. And this was measured by total CK under the curve. The importance of this study is that it confirmed the existence of myocardial reperfusion injury in man, in that if you could apply an intervention at the onset of reperfusion, and if you can reduce the amount of infarction or myocardial injury during that setting, then you've shown that that reduction in infarction was due to the reperfusion itself. Since this study, there's been several publications which have confirmed that ischemic postconditioning is beneficial in primary PCI. Studies have shown better myocardial perfusion and ST segment resolution, and also reduction in infarct size using other imaging modalities such as SPECT and cardiac MRI. The longest follow-up of patients showed a 1-year improvement in ejection fraction using echocardiography. However, not all the studies have been positive. There has been some negative studies, and this may relate to the complexity of the ischemic postconditioning protocol. Ischemic postconditioning may not be effective in all STEMI patients. As we know, patients with the smaller infarcts may not derive any benefit from an adjunct to reperfusion, and it may be the patients with the larger infarcts that benefit. Also, if you're measuring infarct size reduction or myocardial salvage, it's important to have a measure of the area at risk, so you can normalize the infarct size to the area at risk. Some of these studies didn't do that. In addition, if you do this postconditioning protocol of inflating the balloon and deflating it within the stent, but you just put into the infarct-related artery, that could have problems. And the question is whether that IPOST protocol should be delivered upstream of the actual stent. We've heard about the Dynamic 2 study. There's going to be the Dynamic 3 study, which will look at the effect of ischemic postconditioning on clinical outcomes as one of its treatment arms. So this will help us determine, one, whether in a very large multi-center study is ischemic postconditioning helpful, or more importantly, can we actually improve clinical outcomes? Ischemic postconditioning is an invasive protocol that requires an intervention applied direct to the heart. However, one is able to condition the heart remotely by applying brief episodes of ischemia and reperfusion to an organ or tissue away from the heart. This phenomenon is called remote ischemic conditioning, where one can apply ischemia and reperfusion to an organ away from the heart to protect the heart. And this is made clinically feasible by actually putting a blood pressure cuff on the arm to briefly induce ischemia in the upper limb. This phenomenon is called remote ischemic conditioning, and we and others have shown that proof of concept studies that this can actually protect the heart against acute ischemia reperfusion injury. The beauty of this, of remote ischemic conditioning, is it's a non-invasive way, non-pharmacological intervention for actually possibly reducing myocardial injury that can be applied after the onset of ischemia and at the time of reperfusion. So it lends itself to STEMI patients undergoing myocardial reperfusion. One of the first studies to show benefit with this was Hans Bochter's group in Denmark, where they delivered a remote ischemic conditioning protocol to STEMI patients in the ambulance. As we heard yesterday, in Denmark, the transfer times are relatively long, and therefore they have time to deliver a remote ischemic preconditioning protocol. And this actually improved myocardial salvage in patients undergoing primary PCI. Interestingly, from this study, it was noted that the patients that derived the most benefit from remote ischemic conditioning were those with the larger LAD infarcts and those with a completely occluded coronary artery. And this reiterates an important point in conducting cardioprotection studies in this patient group, that you need to select the patient group. It needs to be the patients with the larger infarcts and the patients with complete occlusion, at least at the time of coronary angiography, because they're the patients which are most likely to experience severe reperfusion injury, and therefore the ones that are most likely to derive benefits from an intervention applied at this time. There was a further Greek study which also showed some benefit of remote ischemic conditioning in primary PCI patients, and they found that this benefit was enhanced in the presence of those patients that had received morphine. Keeping on the same theme of mechanical strategies for cardiac protection, there's also the possibility to deliver intracoronary hyperoxemic perfusion, and this approach is therapeutic hypoxemia. And this has been shown in animal studies to reduce infarct size and has been applied in the clinical setting. However, as you can see, by the time you put the catheter in and put the oxygen perfusion up, most of the hyperoxemic perfusion was happening after the onset of reperfusion. And this may explain why there was not much benefit in terms of reduced infarct size, because the delivery of the hyperoxic perfusion was after the onset of reperfusion had taken place. However, a pooled analysis of the anterior infarcts between the AMIHOT 1 and 2 studies did show some benefit. Another mechanical approach is therapeutic hypothermia. Yesterday or the day before, we heard about hypothermia in cardiac arrest situations. It is possible to deliver therapeutic hypothermia to patients arriving with an ST elevation MI. And the most recent study, the Rapid Eye study, it's a small proof of concept study, feasibility study, showed that in 20 STEMI patients, one could deliver therapeutic hypothermia before reperfusion and delay the primary PCI. And the intention is to get the patient to less than 35 degrees. However, this is an invasive strategy and requires giving the patient medication to prevent shivering. There's now the ongoing CHILL-MI study, which is ongoing in Sweden and other countries, to see if they can confirm the benefit of therapeutic hypothermia. So in this proof of concept study, they found there was a 38% reduction in the infarct size expressed at the area at risk, as a percentage of the area at risk. So we talked about mechanical strategies, and many of the preclinical studies which have looked at the mechanisms underlying post-conditioning, preconditioning, and remote preconditioning have identified several pharmacological targets that can be used in the clinical studies to see if we can get the same protection as with the conditioning. And there's a bunch of them here, and I'm just going to go through a few of them. But essentially, one can protect the heart by stimulating special pro-survival kinase pathways within the cardiomyocyte, many of which terminate on the mitochondria. And if by protecting your mitochondria during that first few minutes of reperfusion, one may be able to realize further benefits in this patient group. One of the first studies to use this approach was the JWIN study, published in 2005. It was a Japanese study, multi-center study, in which they delivered intravenous carperitide, which is an analog of atrial natriuretic peptide. This agent in animal studies has been shown to reduce MI size when given at reperfusion. And in this particular study, they randomized 570 STEMI patients, all comers, to receive a carperitide infusion for 72 hours. This had modest beneficial effects with a 14.7% reduction in total CK. However, this was again on all comers, and maybe if they just focused the study on those higher risk patients, the one with the larger infarcts, those with impaired LV function, they may have seen a greater benefit. Talking about protecting your mitochondria, the mitochondrial permeability transition pore has been shown to be a critical determinant of reperfusion injury. And Michel Ovise's group in 2008 have applied this to the clinical setting. The immunosuppressant cyclosporine A, which is used to prevent rejection in transplantation, also can prevent the opening of the MPTP and protect the mitochondria against reperfusion injury. So in this proof of concept study published in the New England Journal, 58 STEMI patients were randomized to receive an intravenous injection of bolus of cyclosporine, 2.5 milligrams per kilogram, which is about half the initial dose that a transplant patient would receive, or a placebo. And this was found to actually reduce infarct size on cardiac MRI and CK. 6-month follow-up has shown persistent benefits in a proportion of patients who had repeated cardiac MRI. If we look at this plot, which shows the infarct size against area at risk, you can see that those patients that seem to derive the most benefit from cyclosporine are those patients with the larger area at risk. So it reinforces and underlines the importance of targeting your therapy for these patients who have the larger infarcts, who have the worst outcomes. There is currently the Circus study, which is a 900-patient multi-center study undergoing in France at the moment, which will look to see if cyclosporine can actually improve clinical outcomes in this patient group. You may have all heard of this study, which was just published, which looked at a PKC delta inhibitor. So we've heard that we know there are protein kinases which we can activate to protect the heart. There are also detrimental kinases which activate cell death pathways such as apoptosis. Protein kinase C delta is one of these pro-death kinases which is activated at reperfusion. And if you can inhibit its activation at reperfusion, one may be able to protect, at least in the animal studies anyway. However, the clinical studies have shown were negative, even when focusing on this high-risk anterior MI group. Now, why was it negative? It could be the delivery of the drug. In the original study, it was intracoronary, but in the larger study, it was intravenous. It could be the patient selection, in that TIMI-0 patients were not specifically specified, but it also could be they did not have an area at risk measure. So they didn't look at myocardial salvage, but just infarct size reduction. Atorvastatin, we know we give this for primary and secondary prevention. These three studies have actually looked at high-dose atorvastatin as a cardioprotective agent in patients and STEMI patients undergoing primary PCI. However, as you know, an oral dose of atorvastatin, 80 milligrams once a day, prior to primary PCI, is not going to reach therapeutic levels by the time of reperfusion. And this might explain that all these three studies were essentially negative. So unless you had an intravenous formulation of a statin, then potentially you could derive benefit from infarct size reduction. We and others have looked at erythropoietin. Erythropoietin is a hemopoietic cytokine which is given as treatment for heart failure. This can be given intravenously at a high dose, and animal studies have suggested that this could reduce infarct size at reperfusion. In a small proof of concept study, we looked at this in STEMI patients, and we randomized patients to receive EPO or a placebo. And unfortunately, we found that it actually had detrimental effects in terms of increased infarct size and doubling of microvascular obstruction. So although the animal studies have suggested that EPO may be beneficial, again, when we put it to the clinic, the studies were negative. And this is just showing a cardiac MRI, something I'll come to later, being used to assess cardioprotection efficacy. And this shows the left ventricle with an area of infarction here with a large area of microvascular obstruction in the LAD territory. Several other studies have been published, much larger, which have also looked at high-dose EPO, and all of them have been negative. So the next pharmacological agent it relates to this, which is a Gila Monster, which is a lizard from Mexico. Interestingly, exenatide, which is a synthetic version of exendin-4, is a hormone that's found in the saliva of the Gila Monster. And exenatide is a GLP-1 analog. So GLP is glucagon-like peptide, which is a new anti-diabetic agent, and which is broken down in the blood. So this analog is resistant to being broken down, and exenatide is being used as an anti-diabetic medication. However, GLP and exenatide can also protect the heart against reperfusion injury. And so this study, which was published in European Heart Journal last year, randomized 171 STEMI patients to receive an intravenous infusion of exenatide or matching placebo. And they found increased myocardial salvage and reduced infarct size to area at risk ratio, suggesting that by delivering this medication, you could actually reduce infarct size. And this was given to both diabetics and non-diabetics, because the beauty of the GLP-1 is that it does not induce hypoglycemia. Interestingly, a subsequent analysis of their data has shown that most patients who benefited from exenatide were those who presented within 2 hours. And as to the time of presentation and the benefits from an intervention given at reperfusion, not much is known. In other words, how much does reperfusion injury contribute depends on the ischemic time and the reperfusion time, but that is not clear, and further studies need to be done to undertake to elucidate that. Most recently, you all heard of GIK, glucose-sensitive potassium. But however, many of the clinical studies, including the large CREATE-ECLA study, were negative in that GIK, or glucose insulin potassium therapy, given that reperfusion, was actually negative in a large study. However, it's to be noted that 68% of the patients received the GIK after primary PCI, which means that the time the GIK was delivered, reperfusion had already taken place. And therefore, this approach of metabolic modulation should ideally have been on board prior to reperfusion. Hence, this study, which was called the immediate study, which was in America, and they gave the GIK in the ambulance to delay ischemic injury or to protect the heart. They had a strange primary endpoint, which this study was negative for. The primary endpoint essentially was to look at how many of patients who had query acute coronary syndrome actually went on to have acute myocardial infarction. And they found no difference between the two. But what they did find, that in those STEMI patients who had GIK given in the ambulance, those patients had less in-hospital mortality and less cardiac arrest, significantly less. So whether GIK was giving some benefit to those patients who were ischemic from an ST elevation MI remains to be shown. There are several other agents being investigated, including melatonin as an adjunct to PCI. Animal studies suggest that melatonin can actually reduce infarct size. There's a PROMISE study, which is being run in Barcelona, which is looking at intracoronary adenosine as an adjunct to reperfusion. And studies in the US and England are looking at sodium nitrite as an adjunct to primary PCI. Nitric oxide is believed to protect the heart from reperfusion injury. So just towards the end of my talk, I'm just going to talk about how cardiac MRI can be used to assess reperfusion injury, but also maybe able to be used to assess the cardioprotective efficacy of these interventions. Cardiac MRI is safe to be undertaken in patients presenting with STEMI undergoing primary PCI, and it can measure infarct size, myocardial salvage, because it can both measure infarct size and the area at risk, but it can also measure other components of reperfusion injury, including microvascular obstruction and intramyocardial hemorrhage. And of course, if you repeat the MRI 6 months later, one can then look at the effects of your intervention on post-MI remodeling. And this just shows a patient who's presented with an LAD infarct. It's not very clear on this projector, but essentially this is an image showing increased T2 signal in the LAD territory, which is suggestive of the area at risk. And if we do T2 mapping, we can see this increased hyperintensity here. And this dropout of the signal is due to microvascular obstruction, which we see on this infarction here. So if we're able to measure the actual quantity or size of the infarct, we're able to measure the area at risk, then we can work out myocardial salvage, and we can apply this technique to future reperfusion strategies. A theme which I've touched on, not only in our field of research, but in many others, is the loss in translation, where one thing is found in animal studies, and when you take it to the clinical setting, you don't see what you expect. And this is because of a number of reasons, but include the design of our animal models. The animal models we use to look at cardiac protection are not appropriate in that we use juvenile, healthy animals without comorbidities. Our patients with infarction clearly are middle-aged or aged, have comorbidities, are on concomitant therapy. And whether we should be using a similar approach that we do to clinical, in other words, a multi-center approach in our animal studies to look at therapies and so we can make sure we get conclusive protection, as suggested by the Horizons AMI, which is a work group of the NHLI, is something we should all work to. In terms of the actual clinical studies, it's important that when we're looking at cardioprotective interventions at primary PCI, we select the right patients, those patients which are most likely to derive benefit. So that requires some accurate measure of area at risk. It's important to take account the duration of the ischemia, and it's important to select those patients with TIMI zero flow at time of angiography and no significant collateralization, because these patients are most likely to benefit. As to the timing of the intervention, if it's to tackle reperfusion, the intervention needs to be there prior to reperfusion and during ischemia. And it's also important that we use relevant endpoints. There's no point looking at endpoints such as revascularization and reinfarction for cardioprotective interventions. We need to look at endpoints which we can realistically improve, such as reduce infarct size, reduce the onset of death, of heart failure and death. So in conclusion, strategies for limiting acute myocardial ischemic injury and optimizing reperfusion in STEMI patients continues to be improved. However, there is currently no therapy for limiting microvascular obstruction and myocardial reperfusion injury. And as such, I would argue this is a residual target for cardioprotection. There are some which in proof of concept studies have shown benefit, such as mechanical, ischemic postconditioning, and remote preconditioning, as well as pharmacological. And these appear promising, but they're all proof of concept studies. Cardiac MRI can be used as a surrogate to assess cardioprotective efficacy, but bearing in mind the limitations of using surrogates. And at the end of the day, proper multi-center, properly powered, randomized controlled trials are needed to investigate whether targeted reperfusion injury can actually improve clinical outcomes for our patients. Just like to thank my colleagues at the Hatter Institute, and thank you for all your attention.
We have time just for 2 short questions for the audience.
A very short question. Out of the variety of possibilities we have to reduce a perfusion injury, which one do you think holds the most promise in the near future to cross the barrier between clinical research and clinical practice?
Yeah, that's a good question. I think probably the 2 pharmacological agents would be cyclosporin and exenatide. As for a mechanical strategy, I think both post-conditioning and remote ischemic conditioning are probably the likely ones. They're the most non-invasive. The therapeutic hypothermia and hyperoxemia seem very invasive. Seem a very invasive strategy.
Thank you very much.